Hello everybody and welcome back to our final video in a series of videos covering all the MMP topics. This is our final video on exam 3 as well as our final video in general. So with that, let's get into it. So acute coronary syndrome, which we briefly covered in our lecture with statins, is a disease that forms clots which cuts off blood flow and oxygen to the heart, suffocating itself. So this is obviously very serious, so we've developed therapeutics to combat this. One class of these are P2Y12 inhibitors. These are essentially therapeutics that will bind to the protein surface and downregulate certain proteins from being produced that allow platelets to come together and clot. One of these is clopidogrel. Clopidogrel is a prodrug, which, as we talked about in previous lectures, is a drug that's essentially activated by the body, or activated when it gets into a certain area. It's the drug you take is not the active form. And it's metabolized by CYP2C19 to become active. So as you can probably guess, intermediate or poor metabolizers of CYP2C19, and I'll write CYP2C19 here, won't be able to activate this drug, meaning you won't necessarily get these desired anti-clotting effects that you want, which is very unideal with a condition as serious as this. There are other antiplatelets that exist other than clopidogrel, but clopidogrel is one of the most used ones still. Even though these other ones may not have this CYP interaction, just because the other ones have much higher bleeding risk, and they're also much more expensive because they're newer. Clopidogrel is an older drug, but we still keep it around just because it's at this point so cheap, and we know a lot about it. And if we do know information about CYP2C19, we can kind of plan around this adverse effect. So warfarin is another ACS drug. It can be used prophylactically to prevent clots, but it can also be used as treatments for clots. The way warfarin works is it's a vitamin K epoxide reductase inhibitor. And essentially what that means is vitamin K will activate a lot of our clotting factors in our body that form kind of the clotting cascade. So if we block these, if we block vitamin K, we're essentially blocking these factors from being formed and then downstream blocking clotting. Warfarin also has two isomers. It has an S and an R isomer. Traditionally, we try and prescribe the S isomer because it's about 5 times more effective. And you may notice that the S isomer is actually metabolized by CYP2C9, whereas the R isomer is metabolized by 3A4 primarily. And this will be important in a second here. Essentially, if a person is a poor metabolizer of CYP2C9, warfarin concentrations will build up. Which you, again, may think is like good because obviously it reduces clot risk. But as warfarin concentrations increase, there's a lot of complications and chances of bleeding risk. Again, this is kind of going back to the idea that drugs want to be dosed at a therapeutic level. You don't want too much, you don't want too little. And that's more of a pharmacokinetic modulator of warfarin. There's actually pharmacodynamics as well, and this is probably something you'll get a question on, is what is the pharmacodynamic like properties of warfarin versus the kinetic versus dynamic, essentially. Something else that can occur is the vitamin K epoxide reductase protein. It's an enzyme, can also mutate. This is the pharmacodynamic regulation. Essentially, if this were to lose function, it would produce less vitamin K, which would obviously lead to less clotting downstream, but could have a higher bleeding risk with warfarin if we overdosed it. Alternatively, if this was always active, patients could have a higher risk of clotting due to more vitamin K being produced. So essentially, there's two factors at play, both these CYP enzymes and the actual function of vitamin K epoxide reductase in the first place, which make it a really complicated drug to work with. There's actually pharmacists that solely dose warfarin for a living. So this is like a very complex drug that requires a lot of monitoring, and you'll learn more about that in therapeutic, just how much you need to like base this on a patient-to-patient basis. Codeine is a medication that's typically given to relieve pain and discomfort during fever. You may have heard of it in like cough syrups and things like that. Codeine is actually the prodrug of morphine, which is obviously a pretty potent like anti-pain kind of drug. You've probably heard of it more in the hospital, but actually when we take these cough syrups in our body, this codeine is converted to morphine, and this occurs through the CYP2D6 enzyme. Um, this is the primary pathway that we ideally want. People that can metabolize codeine into morphine obviously will have a greater degree of pain release, but people who are a poor metabolizer uh, won't be able to get this pain release because the codeine itself doesn't really have an effect on our body. It's the morphine. Um, there's also another pathway is too much morphine in the body can cause toxicity. So ultra rapid metabolizers that convert too much codeine into morphine can actually see toxicities, which isn't good. Um, so again, like therapeutic index, we want just the right amount. So knowing somebody's CYP2D6 status, 2D6, we really want to be able to dose them in an appropriate range more than anything. Codeine is an opiate, and with that, tramadol is another opiate. It undergoes a similar kind of metabolism with CYP2D6. Um, and something just to note is since these are both opiates, if they do have that high concentration with toxicities, they can be reversed with naloxone. That'll more be a question you get in like something like OTC or maybe even like farm practice, but just something to be aware of just for practice. Next, let's talk about proton pump inhibitors. So think like omeprazole. I believe you cover these second semester of OTC unless the curriculum's gotten moved around. Um, Essentially what these drugs are is they prevent the gastric pumps in our stomach from lowering the pH of our stomach, making it more acidic. That way, if you have a disease like gastroesophageal reflux disease or GERD, um, when your contents of your stomach move into your esophagus, it'll be less acidic and cause less burn damage. And these drugs are actually prodrugs, but they're actually not activated by an enzyme. They undergo a rearrangement in the stomach due to the acid. So it's kind of like a really unique design in the fact that the more acid there is, the more they will get out of their prodrug form and into their active form. So they're pretty smart in that sense. Um, but while they are activated in the stomach, they're deactivated in the liver by metabolizing enzymes, CYP enzymes specifically, like most of these drugs. PPIs specifically are metabolized a lot by CYP2C19. So as you can imagine, poor metabolizers and intermediate metabolizers will have these drugs around longer, just because they're not being excreted from the body as much. And people that are poor metabolizers and intermediate metabolizers actually are shown to have their pH be higher or less acidic for long periods of time, which is obviously pretty beneficial. Um, However, ultra-rapid metabolizers may have their pH be lower after a certain amount of time or more acidic. So that's less ideal. And PPIs are actually pretty good drugs in the fact that they don't really have adverse effects very close to the range we give them. So this is a case where you almost kind of just always want more. You want to be a poor metabolizer, CYP2C19 when taking a PPI, because you're not really going to get like those toxicities like you would with like, codeine, like we talked about on the previous slide, if you have too much of it in your system. PPIs are pretty benign, all things considered. Next, let's talk about some neurodrugs. So one class of these are SSRIs, or selective serotonin reuptake inhibitors. And essentially what these do is these will block off serotonin reuptake channels in the brain, or channels that bring serotonin back into cells. And this allows it to stay kind of more near synapses of neurons, which are spaces in between cells, so they can be used as neurotransmitters and signal more because it's been shown that there are effects between mood and serotonin signaling. Citalopram is an SSRI. It's primarily metabolized by CYP2C19. So again, it can block those serotonin reuptake channels. With these, it's another classic case of therapeutic window. If CYP2C19 metabolizes citalopram too quickly, in like an ultra rapid metabolizer, you'll get less of a therapeutic effect. However, if you don't metabolize enough, you can get what's called serotonin syndrome if too much citalopram is around. And serotonin syndrome is essentially just an excess of serotonin in the brain that can hit a multitude of different receptors. So if you have too much and it's hitting receptors that it's normally not supposed to, you can have different mental symptoms. Obviously, serotonin drugs are typically taken for like depression, anxiety. These serotonin syndromes can actually worsen those symptoms and exacerbate them. So we obviously want to dose these in a good range whenever we can. Another class of psych meds are tricyclic antidepressants. Two really older ones are amitriptyline and nortriptyline. You still may see these dosed a little less commonly than some of our newer drugs. Something kind of interesting with them is amitriptyline is the prodrug of nortriptyline. However, these actually both work as like neurodrugs. Essentially, they're both inactivated by CYP2D6. However, amitriptyline can go through CYP2C19 to become nortriptyline. And it's been shown that in some of these patients, nortriptyline is more effective, and in some patients, amitriptyline is more effective. It's kind of just up to the prescriber what they want to prescribe first if they are giving these. But it's just kind of interesting that a drug can be turned into another active drug through CYP activity as well. Because I feel like a lot of what we talked about in this course is usually being either a prodrug that activates something or a CYP enzyme that is like inactivated, or a drug inactivated by a CYP enzyme. So it's kind of interesting that in this case, you just create a different active. So I just wanted to put that on your radar. You probably won't get too many questions about those too, but it's just kind of interesting. So acute lymphoblastic leukemia is a bone cancer. And if you remember, red blood cells and other blood cells are actually produced in the bone marrow. So essentially what this cancer will do is it'll create overproliferated and faulty blood cells. Luckily, we do have an anti-cancer drug for this. It's called 6-mercaptopyridine. This is a prodrug, and essentially it will go through a metabolism pathway in the body to turn into what's called a TGN, which is the active metabolite. It also has another pathway it can take through this TPMT enzyme, which metabolizes it into an inactive. Um, Cancer drugs obviously have very like sensitive therapeutic windows because they modulating how fast the cell should multiply or divide is like very um, there's not a whole lot of wiggle room with something like that. Um, And unfortunately, TPMT, the enzyme that'll turn it into the inactive, is a little bit prone to mutation in some cases. So intermediate or poor metabolizers of TPMT have been shown to have increased myelosuppression, which is kind of like under proliferation of cells, and cause a lot of adverse effects because we essentially when TPMT is mutated and we're taking less drugs through this pathway, more will go to the TGN pathway and will essentially hit DNA more to the sense where our cells, even the non-cancer cells, aren't multiplying as much and cause immune responses, which is like really bad. So again, it's just another classic case of we want these drugs to be in a therapeutic window rather than have too much or too little. So knowing that TPMT status for 6-mercaptopyridine is really important. So chronic myeloid leukemia is another type of leukemia that occurs when a mutation crosses between chromosome 9 and chromosome 22. You might actually be asked those numbers. I feel like we had a question on that, so I would keep 9 and 22 just in your mind. And that'll form, again, chronic myeloid leukemia. And the end product of this is what is called a BCR-ABL protein. This is a protein that downstream promotes proliferation. But the problem with this mutation specifically is where this mutation would normally require like binding of ligands to increase proliferation, which makes sense. As our cell gets signals, it will know when to multiply. It's always on in this mutation. So the cell is always trying to multiply, which is like very textbook kind of cancer behavior. We do have a drug for this. It's called imatinib or Gleevec is the brand name. I believe this hasn't gone generic yet. So I would honestly recommend remembering just brand for this one, Gleevec, but you might also see imatinib on the test. I think we were asked Gleevec though. Um, and essentially how this does is there's ATP binding sites in the cell that even though this protein's on, it still needs ATP to function. It just always has those channels like open so it can function with ATP. So what imatinib will do is it'll actually just block this ADP-ATP binding pocket and totally cut off the signaling cascade, which is pretty handy. The problem we're encountering now, though, since cancer is a very resilient disease that's constantly mutating, is there's actually variations of this BCR-ABL protein that have mutated their ADP-ATP binding pocket, so Gleevec or imatinib don't actually bind to it, making it ineffective. So again, like just cancer being a very difficult disease to treat based on the fact that it tries to mutate around how we can kind of clear it. So now let's move away from leukemias and into carcinoma. So carcinoma is a disease that typically takes place in the epidermis, which can cause kind of like epithelial cells to multiply too much and form tumors. These are usually more treatable types of cancers for the most part. The way this works is, or at least in this case, is there is a protein called PTCH1, which is an inhibitor of this signaling molecule SMO. Now PTCH1 can be deactivated when like during an appropriate time for a cell to multiply and release SMO, which will have a pathway of downregulation that will lead to multiplication. However, as you may have guessed, if something like PTCH1 is mutated to always be inhibited, then SMO can be released and cause overmultiplication. We do have a drug actually. Instead of fixing PTCH1 if it's mutated, we found it was actually easier to create a drug vismodegib to inhibit SMO and attack it directly, preventing it from going through its cascade. But similar to the previous slide, there are actually some cases in which the cell will mutate around this, making it very difficult to treat. Fun fact about this one, the signaling molecule that inhibits PTCH1 is actually called sonic hedgehog signal. So that's just kind of fun. It's because apparently on the protein surface it's kind of spiky, like Sonic is. So I just thought that was fun. So if you see something about sonic hedgehog signaling on the test, that's what that's talking about. So the last disease state I want to talk about is sickle cell disease. This is essentially a disease where there's a mutation in hemoglobin, which if you remember is the protein that can carry oxygen in red blood cells. And essentially what it'll do is where red blood cells are usually kind of this rounder shape, they'll form these like misshapen, kind of spiky, hooky kind of shapes. And what this can lead to is not only oxygen being delivered more poorly, but it can also lead to like clotting if these get stuck on each other. As we develop, we actually have two types of hemoglobin, or three technically. We have alpha, which in when we're fetal, still in the womb, it's bound to gamma hemoglobin, and this is really, really good at transferring oxygen. But as we start to develop and turn into adults, it's replaced with this beta hemoglobin, which is worse at delivering oxygen, but it's still fine for the purpose of being an adult. It's easier to produce, among other things, so we just express it more as an adult to save resources. So researchers had this idea to use this technology CRISPR-Cas9, which is essentially a gene editing technology. You can cut out a defective gene and put in a working gene. So they thought, if we replace defective beta hemoglobin with gamma hemoglobin, we might be able to better deliver oxygen in these people and fix the shape of their blood cells. So that's exactly what they tried. Cas9 is a protein in the system, which is essentially like the scissors, if you think of it like cutting DNA. It will move along to a certain DNA segment that has a faulty gene, which the mechanisms of that are kind of beyond the scope of this class. Just know that it knows where to go and it knows how to cut. And then along with those scissors, what's called a single guide RNA will essentially replace the DNA strand that was cut out. So you can think of it as like DNA as being double-stranded. You can kind of insert an RNA if there's just a single strand of DNA left to create a new strand of DNA. And this single guide RNA will match with the DNA gene we're trying to insert. And essentially what this can do is we can cut out the beta hemoglobin and replace it with something like gamma hemoglobin, or at least like a working beta gene, in order to make cells produce these. And inserting them into the body is again like kind of beyond the scope of this class. There's different ways to do it. You can like modify stem cells and insert them back in the body, is the primary way we do it right now. But yeah, it's a really cool technology. I definitely keep an eye on this one, especially if you want to go into a more research-oriented career, because this is like a really huge recent technology. And then I guess we can just finish up the class by talking a little bit about some more genetic testing. We covered this briefly in the first series of lectures for this course. I mentioned before that the FDA regulates the physical test, make sure the ingredients are pure and safe, but they don't actually regulate like results from genetic tests. Uh, and I think I mentioned before as well that genetic tests may, like if it's 23andMe, probably only look at like one or two chromosomes, certain areas, to get an idea of what your ancestry may be, but it really may not be fully indicative of what's actually going on, which the FDA currently doesn't regulate, nor probably will it ever. Yeah, at least in my opinion, I don't think it will, but who knows? Um, and so, that's a little disappointing. There is resources out there that you can use as like levels of evidence for genetic tests. Just if you were interested in like maybe my CYP2C19, I'm a poor metabolizer, or something like that. So a study came out and it kind of ranked the validity of these. I believe the yellow being the highest level of evidence and the ones and twos being lower. So kind of interesting. If you were really interested, you could look into some of these tests. Um, but yeah, again, like take all these with a grain of salt. They're very useful when we can have clinical administered tests, but like a lot of the over-the-counter kind of like public knowledge tests aren't as great. But yeah, with that, that's the end of MMP. Thank you so much for listening, and good luck on exam 3 and your final.